before we get started. One is a particular welcome to the infectious diseases fellow applicants that are joining us on Zoom. Welcome every week. On Wednesdays, we have an HIV Grand Rounds here at San Francisco General that is focused on high yield clinical learning and cases that are related to people living with HIV. And this week, we're thrilled to focus on cardiology. Before I move on to our speakers, I also just wanted to share, we have a slide up here reminding us all that the medical management of AIDS and key infections, MAKI, if I'm saying that right, Diane, is that, who knows, is coming up in the beginning of December. You can see that the QR code linked here if you'd like more information. And thank you to Meg Newman for providing a bit of introduction to this here. This course is a really phenomenal overview in both foundational topics and sort of what's new, what's current in HIV management, as well as those key infections. And so if you've never attended, would definitely recommend checking it out. And for those of you that are speaking or regular attendees, just a reminder that it's coming up. Okay, without further ado, I will introduce our two phenomenal speakers. We are lucky to have Dr. Matt Durstenfeld, who is an assistant professor of medicine in the Division of Cardiology here at San Francisco General, where he is a general cardiologist and really advancing the field in patient-oriented research to prevent and manage infection-related cardiovascular disease, particularly related to HIV, SARS-CoV-2, and TB. And followed by Dr. Durstenfeld's piece, we'll have Dr. Jonathan Davis speak, who is an associate professor in the same division of cardiology and the director of the heart failure program here at San Francisco General. He is a well-decorated educator, and we're thrilled to have both of them talk. I will turn this over to Matt and just say that each of them, we have 4 cases, if that's right, and we'll briefly pause after each of them to get questions from the audience. So start thinking of your questions and put them in the Q&A if you're on Zoom, and I'll get to them. Thanks.
Thank you for the introduction, and we're delighted to be here today. So I do have, I've received consulting fees from Merck. I'm not related to this work, and I have some research funding. So again, this is going to be case-based, and we're going to focus on a few topics related to cardiovascular disease pertinent to people living with HIV. So this is the first case. This is a 62-year-old man with HIV and hyperlipidemia. He's currently on Descovy and Tivicay. I don't know if I'm saying that right. He has a family history of myocardial infarction, and he has never smoked. His blood pressure is well controlled. So many of you may know that Reprieve, which is like the biggest cardiovascular trial in HIV probably ever, came out last year. And there's a couple of new recommendations based on that, which is the British HIV Association recommends that all people over HIV are recommended for statins. The US Department of Health and Human Services Guidelines Panel for the use of antiretroviral therapy in adults and adolescents with HIV came out with a slightly more nuanced recommendation that has something to do with the number needed to treat from Reprieve, which is basically that for anyone with at least a predicted risk greater than 5%, they recommend a moderate intensity statin, at least a moderate intensity statin. And the panel favored initiation in those over age 40 with a predicted risk less than 5%, but it wasn't like a decisive unanimous agreement. And so for those with predicted ASCVD risk less than 5%, an individualized approach was recommended. There are some exceptions, like people with diabetes, people with really severe hyperlipidemia, where you might jump straight to a high intensity statin. So this is our patient's lipid panels, first checked at least in EPIC in 2020. And I put the numbers in red just as they show up in EPIC. So these are obviously high, other than his HDL, which is great. But these LDL numbers are quite high. We get very concerned about familial hyperlipidemia syndromes with an LDL over 190. And this patient was prescribed rosuvastatin 40 milligrams throughout this whole time period on all of these lipid panels. And then ezetimibe was actually added after this last lipid panel in 2024. And just for the sake of calculating the ASCVD risk, I tried to put it in the calculator and it gave me an error message because his LDL was over 190. I didn't try again with this 2021 where he was actually taking his rosuvastatin. So why is he so hyperlipidemic? So it's clearly not that we haven't made the diagnosis or that we haven't prescribed the medications. Here it comes down to adherence. So why don't people take their statins? Well, some people don't think hyperlipidemia is bad. They aren't worried about it. Some people think that taking a statin won't help. Some people think that statins are really dangerous, and so they don't want to take it unless they really have to. Other people have cost or difficulty accessing treatment. This is almost never a barrier for statin treatment because it just usually is free or costs a few dollars per month at most. Some people don't like to take pills, and then some people don't mind taking them, but just don't remember to take them. So for this particular patient, when I talked to him, he said he doesn't really like taking pills. He definitely doesn't bring them with him when he travels or when he has social things going on because he doesn't want to feel sick. And he feels like taking a pill would make him kind of take on that, they make him feel like he's sick. So what about statin intolerance? So some people do experience statin intolerance, and there's some data saying this may be a little bit more common among people with HIV. There are minimal true adverse events with statins. They're quite uncommon, except with older statins like lovastatin and simvastatin, which are extensively metabolized by the CYP system. And atorvastatin and rosuvastatin do have some modest interactions with other medications, including some older ART regimens. But 90% of statin intolerance is nocebo effect. And this is a really interesting N of 1 trial that was published about 3 years ago, where they basically randomized people to either take placebo tablets or take statin tablets, and then report when they thought they were having symptoms. And sorry, they also had months where they didn't take anything at all. So you can see here in this gray box here, this is when they were randomized to take nothing. And then when they were randomized to take placebo, they had basically the same amount of adverse symptoms like muscle side effects as when they were randomized to take statins. So it's really the perception that statins cause this rather than the actual statin itself for almost everybody. And so usually we can try just changing the statin around, and that often fixes that. And in terms of medication interactions, or will we increase the risk of statin intolerance or muscle myopathies from statins? It's much less of a concern now for patients who are on INSTI-based regimens because you're not worried about the CYP interactions. So what are my options here? You can try a different statin. Obviously, it won't help for our patient who doesn't remember or doesn't really feel like taking his statin. And then you can try a non-statin option. And so those are really for patients who can't take it, or the 1 in 1,000 who have a true adverse event. So the 3 main options that we have that have evidence behind them are ezetimibe. Ezetimibe is kind of works a little bit, but is not great. Bempedoic acid is kind of the newer kid on the block that now has outcomes data in the general population. And then PCSK9 inhibitors are the most effective treatment for lowering LDL, but they do require injections. Now we can do them just every 6 months, kind of like a flu shot. And they're really only accessible currently for people with prior events or severe familial hyperlipidemia. So because you may not be familiar with bempedoic acid, I thought it was worth just mentioning briefly. The first trial showing the safety and efficacy of bempedoic acid to reduce LDL was published in the New England Journal in 2019. And it's an inhibitor of ATP citrate lyase. And this trial really used it on top of statin therapy, not as an alternative to statin therapy. And interestingly, it reduced both LDL and high sensitivity CRP. And then last year, the CLEAR Outcomes trial came out, which showed that bempedoic acid reduced the primary endpoint and MACE by 15%. So this is pretty meaningful. And interestingly, shown here on the right, it decreased LDL cholesterol by about 20% and also decreased high sensitivity CRP by about 20%. So kind of thinking about statins as potentially have an anti-inflammatory effect, bempedoic acid probably has similar benefits. So we're currently doing a trial called the HIV CLEAR trial here in UCLA. We're enrolling now. Please feel free to reach out and email us if you have patients who might be interested. What about PCSK9 inhibition? So PCSK9 inhibition, again, this is kind of the most intensive option that we have. It does require either every other week or monthly injections. Although now with we have newer treatments that are available that can be injected only every 6 months. And so we're currently studying this in the EPIC HIV study, which has now completed enrollment, and we're just in the follow-up phase. So we should have results hopefully next year. Just here at San Francisco General, we're also looking at what patients prefer. So we're doing a survey in Ward 86 and interviews funded by a CFAR administrative supplement. Questions about hyperlipidemia in HIV before we move on to the next case?
Statins, managing with it, non-aligned.
75.
Yeah. So the question is about the approach to managing patients over age 75, because much of the data that we have on statins is really in younger patients. So we know that that in order to benefit from statin in terms of primary prevention of an ASCVD event, you have to take it for years. Most people aren't going to have an event in the year that they're taking it, in the first year they start. But as people age, their risk of events increases dramatically with age. So it's kind of there's less evidence to support use of statins, but I generally will still continue them in patients over age 75. If patients are over age 75, have a low predicted cardiovascular risk for their age, and have no prior events, then it's more of a risk-benefit discussion, and they may be at slightly higher risk of adverse events or intolerance.
Any other questions? We have a working mic. Over. Thanks.
Okay, so this case is a 54-year-old man with HIV and coronary artery disease. He was diagnosed with HIV about 25 years ago, and his CD4 nadir was less than 200. He had a myocardial infarction in 2016, so about 8 years ago, and had a stent placed in his right coronary artery at that time. He's overall been doing well, and his most recent echocardiogram showed he had an EF of 55%, which is kind of at the lower limits of normal. And he had some mild hypokinesis in his inferior wall, consistent with his prior MI. He has occasional chest pain when walking up hills or rushing to catch the bus. So how do patients do after they have an acute coronary syndrome or revascularization if they have HIV? Well, this systematic review and meta-analysis, which was published this year, suggests that people with HIV have increased risk after they have ACS or after they are revascularized, compared to people without HIV. There's a few major limitations to this review. It includes both acute coronary syndromes, where we know we can prevent people from dying, and it includes kind of chronic stable angina revascularization, where we're not going to have that benefit. And importantly, this does not compare people getting revascularization versus medical therapy. So this is just saying, if we take a bunch of people who had heart attacks or who got a stent or bypass surgery with HIV compared to without HIV. Why do people with HIV have increased atherosclerosis? There's a number of proposed mechanisms. A couple that I want to highlight. One is LDL. So we just talked about cholesterol management and the importance of prescribing patients with HIV statins to prevent that. And so I'm going to talk a little bit about inflammation now, which is a major driver of accelerated atherosclerosis in people with HIV. Another thing that I just want to point out is that people with HIV do have increased traditional risk factors. So smoking and metabolic syndrome may also contribute to that increased risk. So what about anti-inflammatory therapy in people with HIV? So there's been a number of small mechanistic trials, including Priscilla Shu's canakinumab study here a few years ago. But in the general population, colchicine is the one anti-inflammatory therapy that has good evidence to support it. And so there's two main trials, both of which are in a secondary prevention population. So in the COLCOT trial, in patients post myocardial infarction, it reduced cardiovascular events over the course of the trial. And then in patients with chronic stable coronary disease who had not had a recent myocardial infarction, it also reduced events. So again, this is secondary prevention. So people like our case 2 patient who already had a myocardial infarction. There's no clinical outcomes data specific to people with HIV. And there is one small mechanistic trial that didn't show a benefit on endothelial function. But I think the big question right now is whether the secondary prevention population trials should be extrapolated to a primary prevention population in HIV. or whether we should just apply this to people with HIV who have already had an event or have chronic stable coronary disease. One thing to just be aware of is that we do have to be careful in patients who have renal dysfunction, hepatic impairment, or if they're on a ritonavir boosted older ART regimen. So what are our next steps for management with this patient who's having some angina? Our big question is, should we cap the patient or not? And the important thing is, no matter what you decide for that question, the patient needs to be on optimal medical therapy to prevent them from having a myocardial infarction. And that includes aspirin, statin, and anti-anginal therapy for symptoms. And then we also want to optimize the risk factors. So if they have diabetes, we want to make sure that's treated, try to encourage them to stop smoking and help them with that if needed. So the main evidence that we have to guide this discussion about whether we should cap the patient is based on the ischemia trial, which randomized patients to an early invasive strategy versus a conservative strategy or medical therapy first and revascularization only if they do not respond adequately to medical therapy. And the reality is most patients' angina gets better. About 2/3 of patients have their angina get better with medical treatment. And so many patients don't need invasive strategy unless the idea is that an invasive strategy could prevent events. So what the ischemia trial showed is that an early invasive strategy has a higher increased event rate with the procedural associated events, and then slightly decreases events over time. But overall, no benefit of the early invasive strategy in terms of preventing heart events. What does it do? It does result in faster symptom resolution for patients who have higher burdens of angina. So our options for evaluation for the patient are we could send them for a cath, an early invasive strategy. We could do a coronary CT, particularly to rule out, do they have severe multivessel coronary disease or left main coronary disease, where we might think about revascularization. We could do a functional study like a stress test. And really, this is kind of an individualized discussion with the patient. And often it can be helpful to have a discussion with a cardiologist about what the best strategy is for an individual patient. And one important thing is that there's really no randomized controlled trial data specific to HIV. And I think the things that inform our thinking about how to take care of our patients with HIV are that patients with HIV are at roughly double the risk of having a myocardial infarction compared to patients in the general population. So we might have a lower threshold to send someone for some sort of further evaluation than we might for someone without. Now this patient comes back and is reporting reduced exercise capacity with dyspnea on exertion, and the EF now is down to 40 to 45% from previously being 55%. So just to remind everyone in this room that HIV is associated with nearly double the risk of heart failure, a relative risk of 1.8 in meta-analysis. And the main driver of this is probably ischemic heart disease, particularly in the United States and in Europe, although there are a number of other contributors to this increased risk. So should we revascularize patients with HIV, which is really the main question we're trying to answer with doing a coronary assessment? There's really two main trials that inform our thinking about this. One is the STITCH trial and then the STITCHES extension trial, which was a randomized controlled trial of CABG versus medical therapy for heart failure with obstructive coronary disease. And this trial was done about 15 or about 20 years ago now, and found no difference in mortality at 5 years, but did find a mortality benefit of CABG over 10 years. But this is really with an older generation of medical therapy. The Revive BCIS trial came out just a couple of years ago now, and randomized patients with ischemic cardiomyopathy with evidence of viability, which is a little bit controversial, but the idea is they tried to set it up to give PCI the best chance of success. So should we stent people with heart failure? And there was no benefit, and you can see these curves are completely overlapping here. No benefit with stenting in this particular patient population, which was an older patient population. Many of them had been turned down for CABG, had really kind of more advanced disease than many of the patients that we see. So we're left with this kind of unresolved question. What should we do? And it's still an area of kind of using our clinical judgment. We did an analysis of our patients here at San Francisco General and looked at two questions. First, one was who gets coronary assessment? And a lot of this is dependent on who is taking care of the patient. But what we notice is that there's some things that don't necessarily make sense if you're trying to assess those who are at the highest risk. So what we noticed is that women were tested much less, and this probably has to do with biases among our providers. Patients who are older were tested less, and this may make sense or maybe not. It depends on what you think of this. And then patients without stable housing that was documented in the electronic health record were also tested much less. And then what we found in our second question is it associated with better outcomes? And what we found here at San Francisco General is that patients with coronary assessment done within the first 30 days of their heart failure diagnosis was associated with 16% lower mortality, similarly with lower rates of death or emergent angiography, so like coming in with a STEMI. Why was this? There's two main contributing explanations. There was much higher rates of revascularization among those who were underwent early evaluation, and then it was associated with much higher rates of use of guideline-directed medical therapy, which is probably the main driver of this improvement in outcomes. And so then the question comes up as well, do we have to assess someone's coronaries to put them on optimal medical therapy? And the answer to that is definitely no. But it's an interesting observation, and it was really challenging to do this study and try to tease out the kind of nuance between these different findings. Questions about management of coronary artery disease and HIV?
Thank you, Dr. Durstenfeld. We have one from online. A colleague from the East Bay. From what I see from our cardiology consultants here, it doesn't seem that colchicine has become standard of care for secondary, let alone primary prophylaxis, even in the HIV negative population. Has this been adopted in other places? And what do you think about potential for standard of care?
Yeah, so that's a great question. So the question is about the adoption of colchicine for secondary prevention in the general population, and then kind of how does that apply to people with HIV? So adoption of evidence on average takes like 10 plus years, which is part of why we have this conversation, right? The point is to learn about the latest evidence and think about how it should be applied to our patients. So the fact that it's been slow to be adopted in the general population, I think is just a reflection of our medical system. But I think the evidence really supports the use of colchicine in patients with coronary disease as a secondary prevention strategy. Now, the reality is a lot of patients are on like 6 or 8 pills and they're reluctant to add another pill. It's kind of the thing I add after they are, on a statin, after they're on an aspirin or clopidogrel or other P2Y12 inhibitor, after they're on a beta blocker. It's not the first thing that I reach for, but in patients who really want to minimize their risk, I am starting to use it more for secondary prevention. I think the question where it comes up, or where I brought it up specific to HIV, is I think that we should be using it more in our patients with HIV for secondary prevention. I don't see it very commonly prescribed, even in the cardiology clinic yet, although we had a discussion in our faculty meeting about how we can increase that. For primary prevention in HIV, that's where I think there's still a really outstanding research question that we don't know the answer of. Will that help reduce inflammation in people with HIV and reduce their accelerated atherosclerosis so they don't have their first MI 10 years earlier than people without HIV?
Thank you so much. Any other questions for Dr. Durstenfeld?
Okay.
Thank you.
I was actually just trying to quickly pull up the guidelines that got updated for chronic coronary disease. There's a section on colchicine, but I don't remember off the top of my head. Matt will check on it. Yeah, it's a level of evidence
1A. It's a 1A recommendation that I think to use it.
So lots of room for opportunity. Again, Jonathan Davis, thank you so much for allowing us to come chat with you all today. Lots of exciting things to talk about. So moving along, thinking about, this is a 38-year-old gentleman with methamphetamine use disorder and heart failure. This person has been using methamphetamine daily since the age of 16. Their echocardiogram shows a severely reduced ejection fraction of 25% with a dilated left ventricle. This person's had 4 admissions in the last 6 months for volume overload and 3 missed visits in heart failure clinic, 0 for 3 in the last year. So does HIV impact heart failure outcomes here? And it does. And I think Matt really eloquently went through a lot of this already. So for the sake of time, I'm going to keep moving through this. But the key, I think, to take away from especially HIV and other inflammatory conditions is things that are inflammatory make heart disease worse. And we see that, and that's one of the thinking about, segueing from colchicine, thinking about HIV, thinking about other rheumatologic autoimmune conditions, that pro-inflammatory states and the anti-inflammatory benefits of especially statins and colchicine as well can have a major impact in reducing the pathophysiology of this disease. But thinking about heart failure specifically, and as a heart failure doc, I'd be remiss if I didn't show a little bit about background on heart failure. This is a nice summary slide from the Heart Failure Society of America last year that shows after your first hospitalization for heart failure, how do you do? And kind of putting this risk into context, both for heart failure folks and patients without. But this is 5-year outcomes of people hospitalized. And the red, looking at the pie graph in the upper left, there are patients with preserved ejection fraction, so ejection fraction in the normal range. The gold yellowish color is for people with reduced ejection fraction, and blue is a sliver of people with this kind of in between, this 40 to 50% ejection fraction that I'm not really going to talk about a whole lot today. It's kind of a data-free zone. Most of the clinical trials over the decades, really since the early 1980s, focus on people with a low ejection fraction or a high ejection fraction. And it really wasn't until some of our newer agents, the angiotensin receptor neprilysin inhibitor, it's a mouthful, ARNI, sacubitril valsartan, and Entresto came out, and the SGLT2 inhibitors, empagliflozin and dapagliflozin, that this kind of middle EF group was focused upon. But kind of segueing also from Matt's prior patient, that folks who have a normal ejection fraction descending to this mildly reduced versus coming up from low to mildly reduced have worse prognoses. So the trajectory of the EF also matters. So here at SF General, I'll touch on this a little bit, we're really treating heart failure as a dichotomy if your EF is normal and if your EF is not normal, with the caveat that the blue box is kind of mildly reduced ejection fraction, just not a very heavily studied patient population in heart failure. But in the upper right-hand corner, thinking about 5-year mortality and thinking about how does your prognosis change if your ejection fraction is reduced versus your ejection fraction is preserved. And you can see the 3 lines completely overlap. It's very common to think, oh, your ejection fraction is 20%, you're in deep trouble. Your ejection fraction is 60%, it's normal, you're probably going to be okay. It turns out once you have the syndrome of heart failure, the dyspnea, the fluid retention, the fatigue, your prognosis is equally as poor. And looking about when half the people have passed away, this is all comers, that by about 2 years after that index hospitalization, about half the folks have passed away. And then if we look at 5-year outcomes down below here, your mortality, this is again, all comers, about 75% of people diagnosed with a new diagnosis of heart failure, any ejection fraction have passed away by 5 years. This is really bad. And it really should trigger us to think, well, what can we do to try to shift this course? And there are a lot of things that we can do to try to make this better. And it's showing it, hopefully you can see at the bottom of the slide here, the readmission rate pushing 80+%. And then by 5 years, again, passing away and having a remission are not quite the same thing, but one or the other happening is almost 100% by 5 years. And putting this risk into context, and especially thinking about the earlier cases, ASCVD risk in patients, which is obviously going to be elevated with people with HIV and other pro-inflammatory conditions. When we think about ASCVD risk, which we calculate in clinic all the time, right? What's your ASCVD risk? Should you be on a statin? Yes or no? Oh my God, it's high. Let's put you on a statin like immediately. And if we think about our risk groups of ASCVD over the year of having an MI or a stroke, at your very high risk is 7+% Then on the right, if you look at your heart failure patients, they may have quote unquote stable heart failure. They're NYHA2, meaning they're pretty asymptomatic. They haven't been hospitalized recently, but that person is at a significantly higher risk. Our high risk ASCVD person is at a lower risk of an event than our lowest risk, quote unquote, heart failure patient. And so kind of putting these last 2 slides into context, that folks with heart failure need to be treated as aggressively as possible to try to shift some of these natural histories. And there are a lot of meds that work. We haven't quite gotten to the point of a lot of poly pills and combination therapies as you have in the HIV space. Colette, one of our recently graduated fellows, did this amazing poly pill project during her 3rd-year fellowship. We're seeing if we can propagate this, where she got a whole bunch of these little gelatin capsules from, and I think she worked in Ward 86 with this as well. These little gelatin capsules from Amazon. She got like 50,000 of these capsules for $10 and took them to Daniel's Pharmacy. And instead of making bubble packs, they wedged the heart failure meds into these little combo pills. So the patient was physically taking one pill, but inside that one pill was 5, 6 different pills. And patients, we'll see what the final outcomes are, but skimming off the top that patients seem to really like physically putting fewer pills in their mouth. But these pills really work. And each of them has a significant impact. The beta block, the 4 key pillars, there's 4 drug classes that have class 1 recommendations for reducing mortality. And this is heart failure with reduced ejection fraction, I should say. Beta blocker, relative risk reduction within 30 days. Again, not having to wait years to see benefits, but within 1 month, a 25% relative risk reduction. Our ARNI, sacubitril valsartan, even over ACE or ARB, cardiovascular death or hospitalization risk reduction of about 40% by a month. MRA, spironolactone, eplerenone, same thing, about 40% reduction, and an SGLT2, a huge reduction in this composite endpoint of death, hospitalization, or worsening heart failure. And it should be noted for the SGLT2s that pound for pound, these probably kick in the fastest, that in the clinical trials for heart failure with reduced ejection fraction, that the primary outcome here was statistically significant at 1 month, 28 days for DAPA, 34 for EMPA. 1 month, the curves were splaying, and actually the heart failure risk reduction for that component of it, of the composite, was about 2 weeks. People were coming into the hospital less with their heart failure being on SGLT2 inhibitor. So overall benefits of these medicines. And I get asked all the time, well, that's a lot of pills. So should we do all of them? Can I start with 1 or 2 and see how it goes? And I kind of have 2 responses depending on who's asking. If it's a provider asking, I'll say, well, if someone has cancer, they need R-CHOP. You don't do R, don't do OP and kind of see what happens, right? You do R-CHOP because that's what works. This is what works for heart failure with reduced ejection fraction. If I have a patient that I'm talking to, I ask them if they have a favorite sport, maybe basketball. Okay, well, great. If you're going to put 3 people on the court, you're not going to win. If the other team, the disease has 5 people on the court, you want to put the full team out on the field, out on the court or the pitch or what have you. So our job is to help navigate this for patients. I joke that I single-handedly keep Daniels and Scriptside in business because I send them so many bubble pack prescriptions. Alto Pharmacy doesn't do this anymore, but they used to have the smart packs, little plastic baggies, which especially for folks that don't have safe places to store their medications, those plastic bags fold up like the size of your fist and can be put in a pocket very easily, whereas the bubble packs are those big sheets. So if anyone in this audience listening knows where I can now send patients for the plastic baggies smart packs, please let me know. But bubble packs are definitely helpful. We haven't kind of mainlined Colette's poly pill yet, but we're heading in that direction. But these meds really work. And not only they work in the short term, they work in the long term. So this is looking at, again, this is all comers, but if you take the quad therapy, those 4 drugs, most people around the country are only getting 2 things, ACE or ARB and a beta blocker. If you look at national registries, and this is still true as of a publication that came out 2 weeks ago, that we're just not doing very well. But if you can put people on 4 drugs, the comprehensive therapy in the blue line, if you started on an average 55-year-old, your average length of life can increase by over 6 years. And if you start on an average 65-year-old, again, this is all comers, that you can increase their life by over 4 years by putting them on comprehensive therapy. I see a question in the back. Yeah, so the question is, do you start all 4 at once or space them out? The answer is you want to start them as fast as you quickly can. During hospitalization, they should be discharged on all 4 drugs without question. There are RCT data to support that. The standard of care in the American College of Cardiology, the best practice statement earlier this year was within 3 months, people should be on everything at maximum tolerated doses. How we get there, there's a lot of ways to get there, but the short answer is as fast and quickly as possible, navigating all the various cost, polypharmacy, social determinant, health literacy, et cetera, issues. But the sooner we get these meds on board, the sooner they start accruing those benefits. And I just alluded to this. This is the paper that just came out a few weeks ago, that we're just not very good at putting people on medical therapy around the country. Even if you look at cardiology clinics, heart failure clinics, that there is a lot of clinical inertia. So I showed huge benefits, but we're just not doing it. And on the left side of the screen, the bars, I'm sorry, it's projecting a little small. Each column is a different drug category. And the blue is if it's being prescribed, and then the red is if it's not prescribed. And you can see even from the back of the room, the red columns, except for beta blocker, are a lot higher than the blue columns. And if you add up the ACE, ARB, and ARNI, they're going to come out close to 100%, which is great. But ARNI really has been shown to be better than ACE or ARBs in terms of morbidity, mortality, sudden cardiac death, hospitalization reduction, mortality, et cetera.
Yeah, thanks so much. Sorry if I'm interrupted. I was just curious, in order for us to better advocate, do you have data on the percentage of people who tolerate being on these versus not tolerating?
I do, actually. I can't remember if I left the slide in for the sake of time or not. The short answer is, if you don't take these meds, you're going to die. And it's not to be blunt. and that the risk of doing nothing is significantly elevated versus the risk of doing something. And looking at almost there's actually a really nice paper just to that came out, I can't remember, it was last year, the year before, looking at 17 major landmark heart failure trials. I can't remember if that slide is in here or not. No, it's not. The placebo is stopped as much, if not more oftentimes, especially SGLT2, than it is stopping the treatment. The rates of severe adverse events are across the board higher in the placebo group. What's a severe adverse event? Dying, coming to the hospital, et cetera. And then smaller things like even, I'll use SGLT2 as another example with the most recent data. In the non-diabetic population, the risk of getting infections and decay and things are exceedingly low in a non-diabetic patient. And in diabetic women, it's actually been shown to reduce the risk of bacterial UTIs. So not treating patients with heart failure, you're not obviating bad outcomes. So doing nothing, they'll feel it. They'll come back to and they can, the fluid retention, the swelling, the fatigue, the hospitalizations and the comorbidities are going to be far more common than the side effects. Yes. That is a great question. So the question is, what is driving suboptimal use? And that's what the figure on the right side of the screen is showing. So in this paper, they surveyed providers across the country and said, all right, why are you not putting people on medical therapy? Obviously, we're very, very lucky here in the San Francisco Health Network that our patients seeing us in clinic with the public insurance San Francisco Health Plan, that all of these drugs are going to be covered. That the co-pays for ARNI, I've seen some Medicare patients who've had a certain Medicare Part D plans that are Medicare Advantage that are terrible, but 90+% of our folks who have San Francisco Health Plan or something similar, the drug cost is not going to be the issue. The biggest barrier is really the polypharmacy in our population. And for sacubitril valsartan, the ARNI, it's BID and necessarily BID. So once a day losartan is going to be better than once a day Entresto. So I will people, if they're going to do better taking once a day regimens, I'll do that. But this, looking at kind of across the country, looking at reasons they're not receiving ARNI, not receiving beta blocker, not receiving MRI, not receiving SGLT2. And MRA is the most commonly forgotten of all the heart failure meds consistently. But you can see almost half the time, the biggest barrier is the provider. The provider thought that the patient was stable and their adequate symptom control, and they just didn't need it. And we can't be complacent like that. That every touch point has to be opportunity, especially for the beta blockers, for example. Some is better than none, more is better than less. That the mortality, the improvement in ejection fraction is very much linked to the dose of the medication. Same thing for sacubitril valsartan. There's some conflicting data, but the take home is that the higher the dose, the more the benefit in terms of reducing mortality and reducing sudden cardiac death. But nationally, it turns out that the providers, rather than the patients, that obviously they're, if you go anywhere else besides here with people with their various private insurances and the cost of co-pays and things like that, are going to come up with a lot of issues navigating polypharmacy. How do I get 4 medicines in someone's mouth every day, plus whatever else they're going to be taking, from a statin to ARVs to everything else. So there are a lot of issues to navigate, but a lot of this lies at our feet. And there's just not a lot of studies. And how am I doing on time?
Like 20 minutes.
Okay.
There are.
I haven't even talked about
chat,
I haven't even talked about methamphetamine yet. So
I'll wave at you when you have 5 minutes.
Okay. Well, hopefully we get there. So there's just not a lot of studies in HIV specific populations. And not only that, to be totally blunt about it, if you look in the heart failure studies, and this is true, unfortunately, for a lot of cardiovascular studies and probably non-cardiovascular studies as well, I'm just not as familiar with all that literature, that most of these heart failure clinical trials are 60 to 70% white men in their 70s. So forget looking at the HIV population, just looking at non-white men in their 70s are woefully underrepresented in the clinical trials just across the space. So, but thinking about HIV specifically, that fortunately there are no drug-drug interactions with ACE/ARB, ARNI, beta blocker, MRA, or SGLT2. They all play in the sandbox very well together. There are really limited data in HIV. Think about the pre-symptomatic stage A and stage B. There are a couple small trials I have listed here, looking at sacubitril valsartan, looking at canagliflozin, an SGLT2 inhibitor that we really don't use anymore for various reasons, and then looking at a eplerenone. But the stage A or stage B, stage A is people at risk for heart failure. So anyone with HIV. So every single person that you're going to see with HIV is going to be stage A for heart failure. Hypertension, diabetes, coronary disease, chronic kidney disease. pretty much any medical condition is going to put you stage A for heart failure. So we don't really use that term. And stage B are folks that if you did an echo, you're going to find something abnormal, but they've never had symptoms. And again, if you have to think about how many echocardiograms do I have to do on the general population to randomly find people whose EF is low and then study them for an outcome, there's just not going to be that much studied there. So the data in this population, not only for HIV, but the all comers is going to be pretty sparse. I did include this slide. So this is looking at the adverse events. And this is the one that I was mentioning. And for the sake of time, I'm going to go through this really quickly. On the left side, this was 17 landmark heart failure clinical trials looking at AE adverse events and seeing, just looking at the table 3, table 4, all the adverse events in the clinical trials and who reported what. And on the left side are some thematic things. So adverse events are common in HFrEF regardless of placebo or intervention, that about 80% of people in both arms had some adverse event. So including 80% of placebo patients, generally speaking, had some adverse event. And the rates of adverse events are typically not meaningfully higher intervention versus placebo. And in the fine print here, talking about SGLT2 inhibitor, MRA, and ARNI being equal and actually a little bit higher with ACE inhibitor having to do with the cough. And then patients randomized to intervention versus placebo have lower rates of severe adverse events. And so that's, again, are you hospitalized? Are you dying from your heart failure? Are you coming back to the hospital? And then some drug specific things with ACE inhibitors, no difference in drug discontinuation between ACEs and placebo in the clinical trials. The biggest thing is increased risk of cough. So obviously, as we're well aware, if we take someone off their ACE inhibitor, put them on an ARB, that hopefully with losartan, that the cough is going to go away. And if we can get people on Entresto, ARNI right off the bat, then you can obviate that. I don't know if it's the official policy in 1M. I think there are probably people here that work in 1M a lot more than I do, but that I'd heard that they were moving towards first line RAS inhibitor be ARB instead of ARNI, just to obviate the cough, and then the anaphylaxis risk you're mitigating as well. Beta blocker, a little bit less likely, 1% to stop the drug, no difference in adverse events, but a little bit more dizziness. MRA, the biggest thing is hyperkalemia and gynecomastia in male patients. If you have a patient on, bless you, if you have patients with spironolactone and a male patient gets any breast, anything, tenderness, soreness, swelling, they point to their breast and say something feels odd, just stop the spironolactone and call it gynecomastia, put it in the allergy list. The longer someone has gynecomastia from spironolactone, the longer it's going to take for that to go away. So if they have gynecomastia for 10 months, it could take a year plus to go away if it goes away at all. So as soon as you think it might be there, just stop it and put people on a eplerenone. And SGLT2, no difference in drug discontinuation. The adverse events in SGLT2 are most commonly in diabetic patients, especially patients with diabetes and more poorly controlled blood sugar. Remember, SGLT2 blocks the sodium glucose transporter. So the higher your blood sugar is, the more glucoseuria you have. The lower blood sugar is, less glucoseuria. So this is why everyone thought this was going to be a great diabetes drug, because you have really hyperglycemia, you'll pee out a lot of sugar. And if you have euglycemia, you won't get hypoglycemic, which is true. It turns out that the adverse events like the mycotic infections, the DKA, are really much more common, A, in diabetic patients, and B, in people that have much higher and higher blood sugars. I've had patients that their blood sugar is running 400 or 500, they have 1 or 2 yeast infections, and then we get their blood sugar under better control. They're now running 100s, low 200s, and they never have another infection ever again, and we're able to keep them on this medication class. But the mycotic infections are definitely something you have to watch out for, especially in women. So I'm going to pivot hard to methamphetamine. And with the last time, talk about some of the efforts that we've done in the cardiology clinic, partnering with our addiction medicine colleagues. And I think some of y'all in Ward 86 are familiar with what we're doing in our Heart Plus clinic, especially because we've really looked to Ward 86 as the model for how to treat this patient population and patient populations like this. Y'all have just an incredibly robust service line of different clinic offerings, type of clinic offerings, drop-in clinics, contingency management, and things like that. So you really are the model for care in a lot of different ways. And so some of this was, as we generated some of our efforts here, very much we're channeling y'all's efforts in the back of our minds and in front of our minds sometimes. So rate of methamphetamine use in San Francisco, red is treatment admissions, orange is ED visits, the greenish triangle is hospitalizations, and the blue line is deaths. And you can see just over the last 5 to 10 years have really severely escalated. And I think I took out the slide for the sake of time, but people that are using methamphetamine and it having be co-occurring with opioid, or the other way around, that the mixed use drug use, oftentimes inadvertent, is also going up significantly. And methamphetamine can cause a lot of problems with the heart. There's myocardial toxicity, so cardiomyopathy, malignant arrhythmias, tachycardia and hypertension, coronary vasospasm, acute MI, aortic dissection. Again, methamphetamine is a very pro-inflammatory state, just like thinking about HIV and other conditions. And it also is an independent risk factor for hypertension, which can drive heart failure, an independent risk factor for hypertension, which can drive coronary disease. So it's, especially kind of thinking about what Matt was talking about earlier with our coronary interventions, that someone comes in and they have a new diagnosis of heart failure, we're working it up, and we're thinking about doing an ischemic evaluation, that just having methamphetamine use, just like just having HIV or just having hypertension, is an independent risk factor for this. So we have to be mindful of that. And we can't have someone with a low ejection fraction methamphetamine use and just write them off and say, yeah, your EF is low because you have meth use, and thanks for coming. We'll talk about all that. I have a patient right now, tomorrow should be meeting with a CT surgeon. Hopefully he makes the visit. He missed last week. Hopefully he goes to talk about revascularization because he has severe multivessel disease and he used meth every day. And we did a coronary assessment. Actually, you might have done it during his admission. And it turns out he has a lot more things going on than he realized. So we have to think that these things don't occur in vacuums. Pulmonary hypertension, sudden cardiac death, infective endocarditis, so lots of different things. And I think one of the most kind of scientifically, medically interesting things about this is they don't overlap a lot. And what I mean by that is I'll see folks with an ejection fraction of 20% and their pulmonary pressures are fine. Or we'll see people in pulmonary hypertension clinic with horrible pulmonary arterial hypertension from this, and the left ventricle is totally fine. That we were chatting about a little bit earlier, that is there perhaps a two-hit hypothesis, a genetic predisposition to one or the other, but we don't really know why. But after seeing many folks with low ejection fractions and pulmonary hypertension from their meth use, I've seen fewer than half a dozen that have really severe PAH and a low ejection fraction. I just have not seen it. So rising prevalence, the rate of methamphetamine emissions has gone up 600% over the last 10-year period. Patients with stimulant-associated cardiomyopathy have a 4-time odds of 30-day readmission, and that's also from our internal data here. People with stimulated-associated cardiomyopathy compared to matched controls, higher rates of mortality, higher rates of acute care utilization, and lower rates of consistent outpatient care engagement. And so there are a lot of barriers. This barely touches on all of them. So there's an unknown pathophysiology and incidence that I was just mentioning. The continuous stimulus drives disease progression and impedes medical care, and there are limited effective treatment options to reduce use. And there's a lot of stigma that is a two-way. Both the patients have stigma against providers judging them, and then providers too often will be biased, say, oh, this patient's back in the hospital again, they're just going to go use meth and go home. And there's a lot of two-way bias that we have to be mindful of and have to address head on. And also social determinants of health. There are a lot of barriers to care engagement in this population. So disenfranchised community who also face their own inequities in care access and resources. I mentioned the social determinant of housing, social determinant of health challenges, clothing, food, and shelter. When they go out of your clinic, how do they get to wherever they're going? Where are they going? How do they get to the pharmacy? How do they get the pills in their mouth? Where are they going to sleep that night? How are they going to get food? So many other things that we have to think about. Mental health disease is also increasingly more prevalent in that population, and other substance use. So, but if we can get people to use less, they can do better just by using less stimulant. And this is the paper I was chatting with a little bit earlier, just looking at if you can stop using. Now, again, depending on how long, if I've been using for 30 years and my ejection fraction has been 10% for a number of years and the ventricle is dilated, there's only so much we can recover from. But kind of if we can catch it earlier and get people to hopefully reduce, but if not, stop using altogether, that the ejection fraction can go up, that the percent having better clinical outcomes can go up. And the primary endpoint here was death, non-fatal stroke, or heart failure readmission. And having improvement in symptoms goes up significantly. So just getting people to use less stimulant. Now, that's obviously much easier said than done, and we're going to talk about that. But cessation of stimulant alone can make a significant improvement in how people do. So and I think a lot of the folks in this room are going to be very familiar with this. So I'll go over this quickly. So the use of guideline-directed medical therapy, so all the GDMT, the beta blockers, ARNIs, et cetera, that is really good, but the use is suboptimal. That there are no FDA-approved medications for stimulant use disorder, and contingency management, a highly effective behavioral treatment that reinforces a target behavior through a reward system. So just again, most people are going to be familiar with this, but contingency management, we want to add something or remove something and increase the behavior or decrease the behavior. So we're trying to do something positive. So we want to promote a behavior. So for the clinic that I'm going to talk about now, we want people to come to clinic. We want people to take their heart meds more and use stimulant less. So increase those behaviors. And we want to add something. So giving them a reward for doing one or all of these things. And so we started our Heart Plus clinic, which is a co-management clinic with addiction medicine and cardiology, trying to co-locate these services, recruiting patients in the hospital. I'll go through some of the workflow for this, but linking the disease of the heart disease and the stimulant use together for the patient, that this is going to drive that and that's going to drive this. These two are linked together, and we want to treat all of you and have you link, oh, I'm coming in, I'm going to see the heart doctor and the addiction doctor together. We're in the same clinic space. We see people together. So really linking the management of these things. And it's a twice weekly clinic structure, thinking about the time that a urine drug screen will stay positive after methamphetamine use of about 72 hours. So each visit, the addiction medicine physician meets with the patient to discuss substance use, symptoms, medication adherence, and do contingency management, which we'll talk about. And then the cardiologist would see the patient at least every week, if not every other, or at least every other week, if not every week, depending on how their heart needs were going. And then each visit we did vital signs, focused cardiovascular exam, and optional point of care urine drug screen. And our fishbowl that we use has 500 slips of paper in it. Half of them are positive affirmations, way to go, keep it up, you got this. And half are for gift cards of ranging values. The most common is the $5 gift card, all the way up to a $100 gift card. And when they first come to clinic, we've actually expanded this to now when we try to meet people in the hospital. I should say that we're, the patient population we were initially trying to treat with this, address and reach with this program, this came out of conversations that, oh, this person, oh, they're back for the 7th time in the last 2 months. They're just going to get diuresis for a day and then go home. And there's a lot of, people being biased and jaded in the hospital about, well, what are we going to do? And so having conversations between myself and the addiction folks, what can we do? So we're targeting this higher risk population that are coming to the hospital acutely with heart failure related to their stimulant use. And so we would meet people in the hospital. We've actually started doing a first priming draw now in the hospital. So our coordinator takes the fishbowl to the patient's room and lets them draw, so they can kind of get that taste there and meet the coordinator there, and then bridge that to clinic. But once they get to clinic, a priming draw, meaning they keep drawing until they win something that's not a positive affirmation. And then as they come, every time they come to clinic in a row, they get to have more and more draws, up to a cap of 5 for attendance. And then every serial negative urine drug screen they get to keep drawing more. So they have 5 serial negative drug screens that they can get up to 5 draws for that. You can show up and decline to do a UDS, and you still get the draw for showing up. So we really want to prioritize people coming to clinic. So these things are independently linked. And I should mention costs. So the perfect attendance, all UDS are negative. The average cost projected is about $615. People come half the time, about half that. And then our initial 10-patient pilot, assuming 50% attendance, was going to be a budget of $3,000. And we actually wound up spending less than this during our initial 12-week cohorts. And I'll talk about how we're doing it now. But just looking at our initial experience with this was a little truncated by COVID. We went live for the very first time the first week of March in 2020. So that did not go very well. We had 2 clinics, a Monday, a Thursday, and then the world shut down. So we were able to relaunch a limited capacity in 2021 and then in 2022. So our N of 22 patients initially, younger patient population compared to your average heart failure folks around 56 years. This was 95% of men. There was 1 woman. You can see the race ethnicity distribution here, kind of 50-50 between stably housed and marginally housed or homeless. More than half was methamphetamine use with cocaine as well, and 1 person used both. And then the results. So baseline creatinine was 1.5, baseline BNP was quite elevated at almost 1,000, and our initial mean ejection fraction was 36%. So a very sick population. And people came to a median of 13 visits, 14 patients completed the program. By the end of 12 weeks in this cohort, 3 patients had stopped using meth completely. All patients reported a reduction in use. Again, it's some is better than more and none is better than less, something like that. The opposite of some is better than none. But even getting to use less can help. All reached maximum tolerated doses of beta blocker, RAS inhibitor, MRA, and sodium and SGLT2 inhibitor. And we used a lot of losartan over sacubitril valsartan because it's once a day instead of twice a day. And metoprolol succinate instead of carvedilol, again, for once a day versus twice a day. And this is what we saw. So this is looking at And the blue is acute care utilization. So coming to the emergency room or being admitted to the hospital, and orange is the clinic show rate. So how many clinic visits do they show up to and how many are scheduled? And in the 3 months preceding Heart Plus, you can see the show rate was about 15%. And that cohort had 47 acute care hospital presentations in the 3 months preceding it. During Heart Plus, it completely flipped. That it went from 47 down to 22 acute care presentations, and the clinic attendance rate was almost 80%. What was also interesting, and something we're still trying to figure out how to deal with, is after the program ended, you can see these things started to reverse again. And so talking about how do we the program was 12 weeks. What do we do after the 12 weeks? We tried this thing called CODA, where we did a 1-month program of just once a week visits, trying to ease people back into primary care and kind of routine care. But we're not sure how to address that. The effect seems to wear off, or looks like it's wearing off. Now, we don't know what happened here. Do these become straight lines, or do they completely revert? We haven't gone back and done, now it's been a couple of years since the initial cohort, but the program was very highly effective. And this is, I think, the second to last slide here. Okay. So after our very first cohort, we did a qualitative assessment. We're just exit interviews, and so asking just how did you do? How do you feel with this program? And there were kind of 3 themes that jumped out, and then below are some quotes from that that I'm gonna read, and it's non-stigmatized care facilitated hopefulness. To have people who give a damn and don't judge you because of what you do or your lifestyle, that's a miracle and a blessing in itself. And to see people give a damn, it's like, wait a minute, they care so much about me, maybe I should care about me. Theme 2, patient-provider relationship was essential. When my doctor pops up behind the glass and she acknowledges that I'm there, that I'm present, it always feels good inside, that I have a person that's rooting for me all the steps of the way. And it always feels good to have somebody that's walking with you through the darkness. And the third theme, Heart Plus changed participants' view of their health and drug use. When I came here, I noticed, oh, I don't crave that much today. I'm clean. I'm supposed to be getting high. This is not me, right? I notice that my using is fading away. Hopefully it'll be for good. And I think this is my last slide. Just looking at our cohort, I showed you there's a larger study done in 2017 with a much larger population. What happens to the ejection fraction? And this was our ejection fraction we had just for 6 people. So we haven't published this. Again, 6 patients, but the EF did improve from 23% median to 52%. So significant improvement with less drug use and more medication use. And so I'm going to stop here. This is just our recap of our various cases. Matt, if you want to come up too, we can take any additional questions.
Thank you both. So phenomenal. 2 quick questions. I'm going to ask one from the chat. They've been waiting. One is, getting to, I think, some of the questions from the back about the nitty gritty of starting GDMT. When folks are limited by blood pressure tolerance, what is the data, or what is your practice around the order in which you start drugs, or sort of practically any tips that you do this? The person asking this comes up in the hospital often.
So fortunately, the SGLT2 inhibitor and MRA are not going to impact your blood pressure. That's been shown in large clinical trials. And then also, if you're in primary care, raise your hand if you've ever used either of them for first-line hypertension treatment, second line, third line. Same thing with metoprolol succinate, right? That we put on our heart failure hat, and all of a sudden we get worried about hypotension of these things. If you have a hypotensive patient on spironolactone SGLT2, that's not those medications' fault. You have to figure out why they're hypotensive. Now, if they're really that sick, that's a different issue. Obviously, if they have really end-stage heart failure and their blood pressure is too low, if they're taking their meds all once in the morning, and they have the flexibility to do meds throughout the day, then splitting some of these things up so they're not physically putting so many pills in their mouth. But really, it's just the ACE, ARB, ARNI that have the most profound blood pressure effects. But low dose metoprolol, 12.5, 25 milligrams of succinate, spironolactone, SGLT2. Sometimes I have patients with blood pressures in the 90s, and the only thing they're on is MRA and SGLT2 and maybe a little metoprolol.
Those were both such great talks. My question was your discussion, John, is reminding us of the beginning of HIV and all these medications and how hard they were to put together, but they absolutely had to be in combination, and they were really too many and too hard to take. And, the drug companies did work together in HIV and put them together. And I know what Colette was doing last year, but that was like
it was awesome.
Getting this kind of plastic thing and like trying to swallow it. What is the impetus from the specific drug companies and cardiology And are they working together and putting them together in one pill and help make, because it sounds like it's imperative, just like in HIV, to have multi-combination therapy.
I mean, you're 1,000% right. The motivation is not there. There have been, you can speak to this just as well, but the poly pill for hypertension for coronary disease, throwing aspirin, statin, and something else in there has shown resounding success in various New England Journal papers over the years. There's at this point no motivation in the heart failure space. Either the meds are brand new and still under patent, or they're 40 years old and no one's all that interested in putting them together. The poly pill that Colette was doing was nice because you didn't have to worry about compounding or pharmacy of the FDA, because you're taking individual medicines and you're just putting them in one bigger pill. That's how I actually learned that bisoprolol is physically smaller than metoprolol. So metoprolol sucks. Have you ever seen that's like the size of my pinky here, whereas bisoprolol is a tiny little pill, both great for heart failure. So at this point, where the short answer is it's just not there.
Yeah, I think they're mainly because they're manufactured by different companies who have their own financial incentives. But there's definitely groups around the country who are working on this issue, and I anticipate that we will have some sort of heart failure poly pill in the next 5 to 10 years. But there's a lot of issues about disagreements between providers about whether they want it to be infinitely titratable or whether they want to just have 3 versions of it. Because unlike ART, where there's like a specific dose for each pill, here there's so many different doses for many of the different components. And there's these 4 different components that may interact differently when people have different renal function or different blood pressure. So it's a little bit more complicated to sort out, but there are definitely groups around the country working on trying to solve this problem. And I think that it'll get solved.
Last quick question. Clinicians are often reluctant still to prescribe beta blockers to people with clear indications, but who use stimulants. Can you comment on this?
You want to start? And I'll...
Sure. This myth, which was from a letter to the editor, I believe, many years ago, is we have shown here for people with cocaine use that beta blockers are totally safe and still prevent outcomes. People who use stimulants are at higher risk of both atherosclerotic events like myocardial infarction, things like aortic dissection, stroke, and heart failure. And beta blockers are absolutely still indicated and safe.
Yes.
Fabulous. Thank you so much. Let's give them a round of applause again.